The last committee to present is provide a network committee, which is just getting off the ground. With all the hard work at DHP to grow the organization we have, the only person who's actively doing that at this very moment is Dr. Scott Dinesen, who actually is not here tonight. He is actually working back at the hospital, the only one who's actively increasing the number of attributed covered lives to Doylestown Hospital. In his absence, Sheri Putnam, who's the co-chair of the committee, is going to make a couple of brief comments.
Having seen Al Ruenis's photos, I'm a little nervous about what Scott Dinesen might come up with as a reply to that next time that he reports to you. So, but on behalf of our Provider Network Committee, just a couple of key points. It is essentially akin to an insurance company's provider network management function, right? So our main scope, large button to the right, our main scope is simply to create the value-driven provider network that supports the contracts. That work falls into essentially participation agreements like those you have seen with most managed care companies. So the DHP participation agreement that Joe Ferrara's governance committee slaved over for all those weeks, it was Provider Network's responsibility to get that out to you and encourage your signatures. I'm happy to report we have 414 providers who have signed to date, over 300 some physicians and their allied health extenders. Ongoing recruitment, we're trying very hard to fill in the gaps. Our job is to ensure network adequacy, they call that in the insurance world. Basically, it means do we have the right number of specialists in the right geography, the right number of primary care docs with appropriate access, and all the ancillary services, everything from ambulances to orthotics to birth control devices and other things that Dr. Ruenis might work with in his office. So it's a big job to identify those gaps. A big one we identified right out of the barrel and we're starting to work on is the behavioral health network scenario in managed care, has typically been a carve-out. IBC in particular started that process carving out behavioral health and mental health services to Magellan, to an outside network with exceedingly limited reimbursement. Most of our behavioral health professionals in our community do not participate in that. That's a gap. We talk to the primary care docs who say most of the chronic care conditions have some underlying behavioral health issues. People have reasons why they drink and eat and smoke and do things that are bad for them health-wise, but we don't really have a solid provision to deal with that aspect of their care. So under the Clinical Integration Committee's direction, the Provider Network Group is starting to work with Dr. Kim and his colleagues in our behavioral health community to talk about not only the physician aspect of it, but there are levels of providers that we don't even know exist or what their functions are. Now, we certainly probably know about certified addictions counselors, but there are family and marital therapists, and there are dietitians and body image therapists. There are all sorts of folks in that field. So we'll be working to develop a solution for that to feed our contracts. The processes that we deal with certainly deal with credentialing. You're sadly, all too familiar with the credentialing aggravation of the managed care companies. We have a responsibility to credential our providers, but our ultimate goal is so that we can have a credentials process that meets the managed care carriers' requirements so that we can take delegated credentialing from them and capture that piece of the premium administration dollar that's associated with that. And lastly, the provider relations function where we attempt to act on your behalf with the payers to reduce the hassle factors that are, again, all too familiar to us. But to the extent that we can standardize processes or we can speak to a payer on behalf of our full network of hundreds of providers as opposed to being one lone voice in the darkness waiting on the phone for a few hours to ask what is probably a simple question. So we'll continue to work down that line, and our duties will expand as our contract success expands. We probably will take the lead in our future relationship leveraging activities. Lots of talk about, we're a local clinically integrated network, a local SIN. Lots of talk about super SINs and multiple SINs and mortal sins and venial sins were pretty much what we talked about in my youth, but it's gotten more important, and our network, provider network group will play an important part in our ability to relate to other networks and ensure that our performance standards are the same. So on behalf of Scott Dinesen and the rest of Provider Network Committee, please, if you haven't already signed your DHP participation agreement, sign it and get a hat.